The intraoperative period begins when the patient enters the surgical suite and ends at the time of transfer to the post-anesthesia recovery area, same-day surgery unit, or intensive care unit. The main concerns of perioperative nurses are the safety and the advocacy for the patient during surgery. Nursing observations and actions can prevent, reduce, and control and manage many hazards. Once in the operating room, the patient is at risk for infection, impaired skin integrity, increased anxiety, altered body temperature, and injury related to positioning and other hazards. The surgical team consists of the surgeon, one or more surgical assistants, the anesthesia provider, and the OR nursing staff. Perioperative or OR nurses include the holding area nurse, circulating nurse, scrub nurse or a non-nurse scrub person, and specialty nurse. The number of assistants, circulating nurses, and scrub nurses depends on the complexity and projected length of the surgical procedure. The surgeon is a physician who assumes responsibility for the surgical procedure and any surgical judgments about the patient. The surgical assistant might be another surgeon or an advanced practice nurse, a physician assistant, a certified nurse first assistant, or a surgical technologist. The anesthesiologist is a physician who specializes in giving anesthetic agent. A certified registered nurse anesthetist is a registered nurse with an additional education and credentials who delivers anesthetic agents under the supervision of an anesthesiologist, a surgeon, dentist, or a podiatrist. The anesthesia provider gives anesthetic drugs to induce and maintain anesthesia and delivers other drugs as needed to support the patient during surgery. The anesthesia provider monitors the patient during surgery by assessing and monitoring the level of anesthesia, cardiopulmonary function, vital signs, and intake and output. Depending on patients' needs, anesthesia personnel give IV fluids, including blood and blood products. Holding area nurses work in those operating suites that have a pre-surgical holding area next to the main ORs. The patient waits in this area until the OR is ready. The holding area nurse coordinates and manages the care while the patient is in this area. Responsibilities include greeting the patient on arrival, reviewing the medical preoperative checklist, and verifying that the operative consent forms are signed. This nurse also assesses the patient's physical and emotional status, gives emotional support, answers questions, and provides additional education as needed. The holding room nurse promotes an atmosphere of comfort, privacy, and confidentiality. Circulating nurses or circulators are registered nurses who coordinate, oversee, and are involved in the patient's nursing care in the OR. The circulating nurse's actions are vital to smooth flow of events before, during, and after surgery. He or she is responsible for coordinating all activities within the particular OR. The circulator sets up the OR and ensures supplies, including blood products and diagnostic support, are available as needed. If there is no holding area nurse, the circulator assumes the responsibility of that role as well. Once the patient is ready to be moved into the OR, the circulating nurse, along with the OR team, assists the patient in transferring to the operating bed. The nurse positions the patient, protecting bony areas with extra padding while providing comfort and reassurance. Through the surgery, the circulating nurse protects the patient's privacy, ensures the patient's safety, monitors traffic in the room, assesses the amount of urine and blood loss, reports finding to the surgeon and anesthesia provider, ensures the surgical team maintains sterile technique and a sterile field, anticipates the patient's and surgical team's needs, providing supply and equipment, communicates information about the patient's status to family members during long or unique procedures, and documents care, events, interventions, and findings. Before the procedure is over, the circulating nurse completes documentation in the OR and nursing records, including the presence of drains or catheters, the length of surgery, and a count of all sponges, sharps, and instruments. Scrub nurses or scrub persons set up the sterile table, drape the patient, and hand sterile supplies, sterile equipment, and instruments to the surgeon and the assistant. Throughout the surgical procedure, the scrub person maintains an accurate count of sponges, sharps, and instruments and amounts of irrigating fluids and drugs used. A specially trained person who is not a nurse may perform the scrub role. Such people are called operating room surgical technologists. Specialty nurses may be in charge of a particular type of surgical specialty, orthopedic, cardiac, ophthalmology, and are responsible for nursing care specific to the patient needing that type of surgery. The specialty nurse maintains and recommends equipment, instruments, and supplies used in that specialty. If the facility uses laser technology, a nurse specially trained in the care and maintenance of laser is needed. He or she may be called a laser specialty nurse or a laser nurse coordinator. LASER is an acronym for light amplification by the stimulated emission of radiation. A laser gives off a high-powered beam of light that cuts tissues more cleanly than do scalpel blades. The process creates intense heat, rapidly clots blood vessels or tissues, and targets tissue into vapor. All personnel must observe safety measures during laser procedures to prevent injury to patient and staff. The surgical suite is located out of the mainstream of the hospital and near the PACU and support services. Traffic flow is patterned to reduce contamination from outside the suite. Within the suite, clean and contaminated areas are separate. The surgical area is divided into 3 zones: unrestricted, semi-restricted, and restricted, to ensure proper movement of patients and personnel. The picture on the left shows a typical OR. The exact number of tables and equipment used in a room is based on the needs of each patient. A communication system links the OR and the main desk of the surgical suite. The system includes an intercom with separate systems for routine and emergency calls. Minimally invasive surgery is now a common practice. Once used only for minor procedures in joint surgery, MIS is the preferred technique for many types of surgery, including cholecystectomy, which is the removal of a gallbladder, cardiac surgery, splenectomy, and spinal surgery. It is even being used for cancer surgeries, such as the removal of a lung lobe called a lobectomy, or even the entire lung, which is called a pneumonectomy, and a colectomy, which is removal of part of the colon. Research has verified that many benefits of MIS include reduced surgical time for some surgeries, smaller incisions, reduced blood loss, faster recovery time, and less pain and other discomfort after surgery. Robotic technology is drastically changing how surgery is performed and how the OR is organized. Robotic surgery takes minimally invasive surgery to a whole new level. Many gynecological or urologic and cardiovascular procedures are being performed by using robotics. The robotic system consists of several components. These include a console, surgical arm cart, and a video cart. Initially, the surgeon inserts the required instruments and positions the articulating arm. He or she then breaks scrub and performs the surgery while sitting at a console. A three-dimensional view of the patient's anatomy provides the surgeon with precise control and dexterity. Minimally evasive surgery involves making one or more small incisions in the area of the surgery and placing an endoscopy through the opening. An endoscopy is a tube that allows viewing and manipulation of internal body areas. Some endoscopies also magnify the view. These instruments may be rigid, semi-rigid, or flexible. Some have light sources, whereas others require that a separate light source be inserted into the surgical area. Endoscopies have different names and shapes for different surgical procedures. For example, laparoscopies are used for abdominal surgery, arthroscopies are used for joint surgery, and ureteroscopies are used for urinary tract surgery. At one time, endoscopies were used only for examination and obtaining specimens for biopsy. Now these instruments can be used by surgeons for organ removal, reconstruction, blood vessel grafting, and many other procedures. An important part of minimally invasive surgery for abdominal surgery, pelvic surgery, and surgery in some other body cavity areas is injecting gas or air into the cavity before the surgery to separate organs and improve visualization. The injection is known as insufflation and may contribute to complications and patient discomfort. It is one factor that is considered when deciding whether to perform a procedure by traditional open surgery or by endoscopy. Mechanical trauma and thermal injury are two categories of injury that a patient can incur during minimally invasive surgery and robotic surgery. One limitation for both minimally invasive surgery and robotic surgery is the cost of special equipment and OR setting. In addition, surgeons require lengthy training and practice periods to become proficient in even one procedure performed using these endoscopic measures. The patient is unable to protect himself or herself during surgery. Protection is provided by all members of the surgical team. The OR layout helps prevent infection by reducing contaminants through air exchanges in the room, maintaining recommended temperature and humidity levels, and limiting the traffic and the activities in the OR. Safety straps are used for the patient, and the operating bed is locked into place. Blankets or warming units are used to prevent hypothermia, and interventions are used to prevent skin breakdown. The nurse ensures electrical safety through proper placement of grounding pads and the use of electrical equipment that meets safety standards. All equipment used during surgery must be functional and in proper working condition as determined by the safety procedure of the facility. Equipment is cleaned and, when required, sterilized so that it can be used as a part of the procedure. The scrub and circulating nurses together ensure a correct count of surgical instruments, sharps, and sponges. Counts are performed before the procedure, during the procedure, as items are added, as closure of the first layer of the surgical wound, and immediately before complete skin closure. People are source of bacteria in the surgical setting. Everyone has bacteria on the skin and hair and in their airways. Because these organisms can be transmitted to the patient, special health standards and dress are needed. Health standards require that all members of the surgical team and other support personnel in the surgical suite be free of communicable diseases. No one who has had an open wound, cold, or any infection should participate in surgery. Good personnel hygiene helps prevent and control infection, as does frequent hand washing. All members of the surgical team and all OR personnel must wear scrub attire while in the surgical suite. Scrub attire is provided by the hospital and is clean, not sterile. Basic surgical attire is a shirt and pants and a cap or hood and shoe coverings. Staff change into clean surgical attire in the OR suite locker rooms, not at home. All members of the surgical team must cover their hair, including facial hair. The surgeon, all assistants, and the scrub nurse perform a surgical scrub after putting on a mask and before putting on sterile gown and gloves. The scrub does not make the hands and the forearms sterile. When the scrub is performed correctly, it reduces the number of organisms from the hands, arms, and nails. Rings, watches, and bracelets are removed before scrubbing because they may harbor organisms. A broad spectrum surgical antimicrobial soap is used for the surgical scrub. Plain or antimicrobial soap is used for washing hands immediately before the surgical scrub. Vigorous rubbing creates friction used from the fingertips to the elbow. The scrub continues for 3 to 5 minutes, followed by a rinse. During the rinse, hands and arms are positioned so that the water runs off rather than up or down the arms. After scrubbing, personnel enter the OR with their hands held higher than the elbows and thoroughly dry their hands and forearms with a sterile towel. This person is then assisted into a sterile gown and puts on sterile gloves. Gowns, gloves, and materials used at the operative field must be sterile. These items are changed between surgical procedures and as they become contaminated. The areas of the surgical gown considered sterile are the front of the gown from the chest to the level of the sterile field. The entire sleeves of the gown are considered sterile from 2 inches above the elbow to the cuff. The back of the gown is not considered sterile because it cannot be consistently seen by the wearer. Only when they are properly scrubbed and attired do members of the surgical team handle sterile drapes and equipment. Anesthesia is an induced state of partial or total loss of sensation occurring with or without loss of consciousness. The purpose of anesthesia is to block nerve impulse transmission, suppress reflexes, promote muscle relaxation, and, in some cases, achieve a controlled level of unconsciousness. Usually, the anesthesia provider selects the type of anesthesia to be used after consulting with the patient and the surgeon and after considering specific patient-related factors. Patient health problems are major factors in the selection and dose of anesthetic. Selection is also influenced by type and duration of the procedure, area of the body having surgery, safety issues to reduce injury such as airway management, whether the procedure is an emergency, options for maintaining pain after surgery, how long it has been since the patient ate, had any liquids or drugs, patient position needed for the surgical procedure, whether the patient must be alert enough to follow instructions during surgery, and the patient's previous response and reaction to anesthesia. Anesthesia can be induced in many ways. The most common forms of anesthesia used in North America include general, regional, and local anesthesia. General anesthesia is a reversible loss of consciousness induced by inhibiting neuronal impulses in several areas of the central nervous system. This state can be achieved by a single agent or a combination of agents. General anesthesia depresses the CNS, resulting in analgesia, amnesia, and unconsciousness with loss of muscle tone and reflexes. The patient is unconscious and unaware. This type of anesthesia is used most often in surgery of the head, neck, upper torso, and abdomen. It is also may be used when patients cannot cooperate. Induction of general anesthesia involves 4 stages as listed on this slide. Major nursing interventions is listed in parentheses for each stage. The speed of emergence depends on the type of anesthetic agent, the length of time the patient is anesthetized, and whether a reversal agent is used. Retching, vomiting, and restlessness may occur during emergence. Although not all patients have these responses, suction equipment must be available to prevent aspiration. General anesthesia agents are administered by inhalation and IV injection. At times, both inhalation and IV agents are used together as balance anesthesia to obtain specific effects. Many combinations are possible, and selection is based on the individual patient and specific surgical procedure. Other drugs, such as hypnotics, opioid analgesics, and neuromuscular blocking agents, may be used as a part of anesthesia regime. Hypnotics and opioid analgesics can be used for sedation for short procedures and as an adjunct to general anesthesia during surgery. The neuromuscular blocking agents are used to relax the jaw and the vocal cords immediately after induction so that the endotracheal tube can be placed. These drugs also may be used during surgery to provide continued muscle relaxation. Complications from general anesthesia can range from minor and annoying, such as a sore throat, to death. Improvement in anesthesia delivery and surgical techniques has resulted in decline in anesthesia-related deaths, even among high-risk patients. Although the anesthesia provider has the main responsibility for monitoring patient responses during surgery, the circulating nurse also remains alert for changes in patient condition. More in-depth discussion of malignant hyperthermia will follow on the next two slides. Overdose of an anesthetic can occur if the patient's metabolism and drug elimination are slower than expected. This is more likely to occur in patients who are older or who have liver or kidney problems. Other drugs, such as antihypertensives, also alter metabolism, and interactions can occur between the anesthetic and the patient's regularly scheduled drugs. Accurate information about the patient's height, weight, and medical history, especially liver and kidney function, is vital in determining the anesthetic type and dose. Death during surgery is usually related to pre-existing health problems than anesthetic overdose. Unrecognized hypoventilation occurs as an anesthesia-induced complication. Failure to exchange gases adequately can lead to cardiac arrest, permanent brain damage, and death. This is prevented by anesthesia provider monitoring end-tidal carbon dioxide, which confirms there is carbon dioxide in the patient's expired gas. Intubation complications can include many problems such as broken or injured teeth and caps, swollen lips, vocal cord trauma. Intubation can be difficult because of anatomic variants or disease presence of a tumor or a small oral cavity, or even having a tight jaw joint. Improper neck extension during intubation also may cause injury. Malignant hyperthermia is an acute, life-threatening complication of certain drugs used for general anesthesia. The reaction begins in skeletal muscles exposed to specific agents, causing increased calcium levels in muscle cells and increased muscle metabolism. Serum calcium and potassium levels are increased, as is the metabolic rate, leading to acidosis, cardiac dysrhythmias, and a high body temperature. Onset of malignant hyperthermia may occur immediately after induction of anesthesia, several hours into the procedure, or rarely even after anesthesia has been terminated. Clinical features reflect increased muscle calcium level and the greatly increased body metabolism. Manifestations include tachycardia, dysrhythmias, muscle rigidity, especially of the jaw and upper chest, hypotension, tachypnea, skin molting, cyanosis, myoglobinuria, which is the presence of muscle proteins in the urine. The most sensitive indication is unexpected rise in the end-tidal carbon dioxide level with a decrease in oxygen saturation. Another early indication is sinus tachycardia. Extremely elevated temperatures as high as 111.2 degrees Fahrenheit is a late sign of malignant hyperthermia. Survival depends on early diagnosis and the actions of the entire surgical team. Time is crucial when malignant hyperthermia is diagnosed. Dantrolene sodium, a skeletal muscle relaxant, is the drug of choice along with other interventions. For a known history of risk, the patient can be treated before, during, and after the surgery with dantrolene to prevent this problem. Local or regional anesthesia briefly disrupts sensory nerve impulse transmission from a specific body area or region. Motor function may or may not be affected. The patient remains conscious and can follow instructions. Local anesthesia is delivered topically. It is applied to the skin or mucous membranes of the area to be anesthetized, and by local infiltration, injected directly into the tissue around an incision, wound, or lesion. Sometimes when the term local is used, it means any form of anesthesia that is not general. Regional anesthesia is a type of local anesthesia that blocks multiple peripheral nerves in a specific body region. It may be used when general anesthesia cannot be used because of medical problems, when the patient has an adverse reaction to general anesthesia, when a patient has a preference and a choice if possible, and when pain management after surgery is enhanced by regional anesthesia. Types of regional anesthesia include field block, nerve block, spinal, and epidural. The nurse's role in the delivery of regional anesthesia consists of assisting the anesthesia provider, observing for breaks in sterile technique, providing emotional support for the patient, staying with the patient, offering information and reassurance, and positioning the patient comfortably and safely. A field block is a series of injections around the operative field, most commonly used for chest procedures, hernia repairs, dental surgery, and some plastic surgeries. Nerve block is injected of the local anesthetic agent into or around one nerve or group of nerves in the involved area, most commonly used for limb surgery or to relieve chronic pain, such as back pain. Spinal anesthesia is injection of an anesthetic agent into the cerebral spinal fluid in the subarachnoid space, most commonly used for lower abdominal, pelvic, hip, and knee surgery. Epidural anesthesia is the injection of an agent into the epidural space, most commonly used for anorectal, vaginal, perineal, hip, and lower extremity surgery. Complications of local or regional anesthesia are related to patient sensitivity to the anesthetic agent, anaphylaxis, incorrect delivery technique, systemic absorption, and overdose. The nurse observes for central nervous system, followed by central nervous system and cardiac depression, which are signs of a systemic toxic reaction. The nurse also assesses for restlessness, excitement, incoherent speech, headache, blurred vision, metallic taste, nausea, vomiting, tremors, seizures, and increased pulse, respirations, and blood pressure. Interventions include establishing an open airway, giving oxygen, and notifying the surgeon. Local complications include edema and infiltration as early problems. Abscess formation, tissue necrosis, and/or gangrene may occur later. Abscesses result from contamination during injection of the agent. Necrosis and gangrene are rare, but they may occur as a result of prolonged blood vessel constriction in the injected area. Moderate sedation, formerly called conscious sedation, is the IV delivery of sedative, hypnotic, and opioid drugs to reduce the level of consciousness but allow the patient to maintain a patent airway and to respond to verbal commands. The amnesia action is short, and the patient usually has a rapid return to ADLs. Diazepam, midazolam, fentanyl, propofol, and morphine sulfate are the most common drugs used. Moderate sedation is used for endoscopy, cardiac catheterization, closed fracture reduction, cardioversion, and other special but short procedures. In most states, Arizona included, a credentialed RN may deliver moderate sedation under physician supervision and within the state-defined scope of nursing practice. Credentialing includes advanced training in IV drug delivery, airway management, and advanced cardiac life support. The nurse monitors the patient during and after the procedure for response to the procedure and the drugs. The airway, level of consciousness, capnography, oxygen saturation, ECG status, and vital signs are monitored every 15 to 30 minutes until the patient is awake and oriented and vital signs have returned to baseline levels. The patient receiving IV moderate sedation can be discharged to go home with a responsible adult if adequate gas exchange and arousal from sedation. The patient is expected to be sleepy but arousable for several hours after the procedure. Oral intake is not permitted until 30 minutes after the patient has received the sedation or according to the physician's prescription. If the patient was intubated or had an oral endoscopy, return of gag reflex is required before resumption of oral intake. When fluids are permitted, the nurse makes sure that the patient is awake and positioned correctly to avoid aspiration. On arrival in the surgical suite, the patient is taken to the holding area or directly into the operating room. The holding room nurse or the circulating nurse greets the patient on arrival. Identification of the patient is the responsibility of every member of the health team. Check the patient's identification bracelet and ask, "What is your name and when were you born?" After completing the identification process, the nurse validates that the surgical consent form that has been signed and witnessed. The nurse asks, "What kind of operation are you having today?" to ascertain that the patient's perception of the procedure, the operating permit, and the operative schedule are the same. When the procedure involves a specific site, validating the site on which the procedure is to be performed is the responsibility of each healthcare professional before and at the time of surgery. The nurse asks the patient about any allergies and determines whether autologous blood was donated. A special allergy bracelet on the patient's wrist and medical record must be verified with what has been communicated. The nurse checks the patient's attire to ensure adherence with facility policy. Dentures and dental prosthesis, jewelry, eyeglasses, contact lenses, hearing aids, wigs, and other prosthetics are removed. The circulating nurse and anesthesia provider review the patient's medical record in the holding area or operating room. The medical record is the main source of information on the type and location of the planned surgery. The nurse checks the medical record to ensure required data are present before surgery is started. Ethical dilemmas may occur during or after surgery. As a patient advocate, The nurse may have to intervene on behalf of the patient's rights and wishes. The nurse must be familiar with advanced directives and do not resuscitate orders for each patient. The nurse asks about allergies and previous reaction to anesthesia or blood transfusions. Allergies to iodine products or shellfish indicate a risk for reaction to the agents used to clean the surgical area. Latex allergies are assessed with all patients. Latex-induced anaphylaxis accounts for about 10% of anaphylactic reactions that occur during surgery. Latex-free equipment and supplies are used when there is a latex allergy. The patient's previous experience with anesthesia helps the nurse and anesthesia provider anticipate needs and plan interventions. For example, if a patient is restless or agitated as a reaction to anesthesia, the nurse can have padding for the side rails and protective restraints available. The OR nurse reviews the most recent laboratory findings and test results and informs the surgical team about the patient's health and to alert them for potential problems. These results are usually obtained within 24 to 48 hours before surgery for hospitalized patients and within 4 weeks for ambulatory surgery patients. The nurse reports all abnormal findings or results to the surgeon and anesthesia provider. Laboratory values greater or lesser than normal range are potentially life-threatening for the patient having surgery. For example, if the hemoglobin level is less than 10 grams per deciliter, oxygen transport capacity is reduced, affecting the amount and type of anesthesia used, as well as the impact of blood loss during surgery. The nurse performs a final assessment for threats to patient safety. This begins with the patient's age and general physical condition. Older patients and those who are thin or overweight are at greater risk for skin injury. Assessing mental status is important because confused patients and those are unable to tell when a problem exists. Patients who have sensory impairment of any type are in increased risk for injury. The OR nurse checks the medical history and examination findings, including usual pulse and blood pressure, are recorded. This information provides the circulating nurse, surgeon, and anesthesia provider and PACU nurse with a baseline data to assess the patient's reaction to surgery and anesthesia. Drugs taken before surgery may affect the patient's reaction to surgery and wound healing. For example, aspirin reduces platelet action, increasing clotting time and the risk for hemorrhage. After completing the medical record review, the nurse may insert an IV catheter and perform a surgical skin preparation. Circulating nurse provides emotional support and explains procedures to the patient. If the patient is in the holding area, he or she is moved to the OR after the preoperative routine is completed. The patient is usually in a supine position after transfer to the operating bed. Anesthesia may be initiated with the patient supine, and he or she may then be repositioned for surgery. The surgical nurse coordinates positioning of the patient for surgery and modifies the position according to patient safety and special needs. Factors influencing the timing of repositioning include the surgical site, the age and size of the patient, the anesthesia delivery technique, and pain on movement with a conscious patient. One of the priority problems for a patient during surgery is potential for injury related to improper positioning. The expected outcome or goal for this NANDA is the patient is expected to be free of injury as indicated by adequate capillary refill and peripheral pulses in all extremities, peripheral sensation and motor function after surgery at the same level as before surgery, absence of skin redness or open areas, and absence of bruising. Interventions are used to prevent injury positioning during surgery. Because of anesthesia and narrow OR bed, the patient's normal defense mechanisms cannot guard against nerve or joint damage and muscle stretch or strain. In addition, pressure ulcers often start to develop during surgery. Thus, proper positioning is important. The circulating nurse pads the operating bed with foam and other silicone gel pads and properly places the grounding pads. Another priority problem for a patient undergoing surgery is potential for infection related to invasive procedures. The expected outcome or objective for this NANDA is the patient is expected to have an unaffected surgical wound or wounds. Indicators include wound edges are closed and not excessively red or swollen. The wounds are free from purulent drainage. White blood cell counts remain at expected levels after surgery, and the patient is afebrile. Surgical wound infections interfere with the patient's recovery, delay wound healing, contribute to rising healthcare costs, and are a major source of nosocomial infections. The CDC defines surgical site infections as occurring 30 days post-surgery and up to 1 year for transplant surgery. Aseptic technique must be strictly practiced by all OR personnel to ensure that the patient is free from infection. Assess the risk for infection, including patients with pre-existing health problems such as diabetes mellitus, immune deficiency, obesity, and kidney disease. The nurse performs the prescribed skin preparation, protects the patient's exposure to cross-contamination, keeps traffic to a minimum, and administers prescribed antimicrobial prophylaxis. Surgery places the patient at risk for wound complications, including incisional tears and lacerations, infection, and loss of body fluid. Sterile surgical technique and the use of protective drapes, skin closures, and dressings reduces complications and promote wound healing. When a wound is already infected or is at a high risk for infection, antibiotics may be used directly in the wound by irrigation or by placing the drug directly into the surgical site before wound closure. Skin and tissue closures include sutures, staples, and special tape. They are used to hold wound edges in place until healing is complete, occlude blood vessels, preventing hemorrhage and fluid loss, and prevent wound contamination. There are other types of devices or items that are used for wound closures, such as glue. You may see that put on the wound itself, and the wound edges then are approximated and held together. Sutures are absorbable and non-absorbable. Absorbable sutures are digested over time by body enzymes. Non-absorbable sutures become encapsulated in the tissue, ensuring the healing process, and remain in the tissue during the healing process, and remain in the tissue unless they are removed. Sometimes they're just there forever and a day. Retention sutures may be used in addition to standard sutures for patients at high risk for impaired wound healing. A variety of dressings may also be used to absorb drainage and support the incision. A pressure dressing may be applied to prevent bleeding. One or more drains may be inserted to remove secretions and fluids from within tissues around the surgical area. These secretions, if not drained, slow healing and promote bacterial growth, which could result in wound infection. After the dressing is secured, the nurse coordinates the surgical team in positioning and transferring the patient. The circulating nurse and anesthesia provider go with the patient to PACU and report the patient's surgical experience to the PACU nurse. Another priority problem for patients having surgery is potential for hypoventilation related to anesthesia, pain, and/or reduced respiratory effort. The patient is expected to be free of damaging events related to hypoventilation as indicated by maintenance of a SaO2, PaO2, and blood pH within normal limits, vital signs within normal limits, and return to pre-surgical level of cognitive functioning. The purpose of interventions is to prevent injury from anesthesia. The nurse, surgeon, and anesthesia provider monitor the patient, including continuous monitor of breathing, circulation, and cardiac rhythms, blood pressure and heart rate recordings every 5 minutes, and continuous presence of anesthesia provider during the case. Then, nurse evaluates the care of the patient during surgery based on the identified priority patient problems. The expected outcomes are that the patient is safely anesthetized without complications, does not experience any injury related to surgical positioning or equipment, is free of skin or tissue contamination during surgery, is free of skin tears, bruises, redness, abrasions, or macerations over pressure points and elsewhere, and maintains normal body temperature.